What I see, or what I'm excited about, is now that we are entering in an era of preclinical diagnosis. So that's, for example, for Parkinson's disease, for Alzheimer's disease, we may predict more or less who will develop the disease 6, 7, 8 years before they start having their clinical symptoms. And I think this is good in one sense, because we will be understanding, or actually we are understanding more about the disease process before it becomes clinically overt. However, it's maybe of not much use today because we have no treatments to prevent it. But we are learning through it. Probably now what we are seeing is that we are maybe moving the therapeutic trials not after that the disease starts, but before it starts, where it might be more effective. I'm not someone who is in the field of Alzheimer or Parkinson's disease, but unfortunately in the last 20 years, almost all treatments, new treatments tried in Alzheimer were failure. But through this now we may learn more and may have more options for the future. And more or less the same would be for Parkinson's disease. So with now molecular imaging, with some CSF or serum markers and genetic testing, we are really entering in an era where we can talk about, let's make your diagnosis before you get the disease and see whether we can prevent it or not, or slow it down or delay it. And I think this is kind of exciting to me. So why I come to this point? Because now we are seeing this in MS, which is my field of interest. And now we have the so-called radiologically isolated syndrome. Well, is it really good to make a diagnosis of MS couple of years before the individual gets their first symptoms? Probably yes. Again, we are learning through that period how the disease will, or how the individual is going to do. Whether they have subclinical imaging progression. Maybe we'll be able to say this through some biological markers, whether they would have also that kind of progression before they develop the disease. Maybe more or better than what we see in Alzheimer and Parkinson's disease, we might have some means to do something if we choose who is a high-risk RIS patient to develop MS, and we may start treatment at that stage. Currently, our approach is not to treat people with RIS, because we know that probably half of them will not develop the disease clinically. And this is something which we have known for many decades from autopsy studies. We know about some publications about people who came to the autopsy table after they have lived a long, happy life without having any neurological symptom, and turn out to have the pathology of MS in their brains and spinal cords. So there is another group of people, despite having morphologically, pathologically the disease, and we know from some CSF study also, have oligoclonal bands and so on, that they don't develop the disease. So that's another issue. One issue is who is going to develop the disease. So what is exciting is some people subclinically have the disease but will not develop. Some others will develop. Some will be high-risk people. So if we can really pick up this group of people and start early treatment, we might be doing something great. And there are now one such study going on in the US, and another one that will start later this year in Europe. And in a couple of years, we might get the first answers to this question.